Welcome to another MedCram COVID-19 update. And let's just take a moment to take a look at the daily new cases worldwide. And we can see here that if we look at a 7-day moving average, the amount of daily new cases has never been higher when we look at it from a worldwide perspective. While we look at daily deaths from a worldwide perspective, and things have pretty much flattened out, still, however, an unacceptable 5,000 deaths per day. And there seems to be a recurring theme, whether you look in the Americas or if you look in Europe, we see cases escalating, but we're not seeing the associated deaths as much as we were seeing in the first wave of this pandemic. And that has not been lost on a couple of researchers who have put forth some peer-reviewed articles on just that topic. And here's an article titled, "Studies Point to Big Drop in COVID-19 Death Rates." One of the studies that was authored by Leora Horwitz, a doctor who studies population health at New York University's Grossman School of Medicine, focused on a single health system there in New York, started out with patients having a mortality that were in the hospital of 25.6%, dropping down to 7.6%. And here, of course, is the preprint before it is to be published. And here you can see the telling graph, which looks at the bi-weekly mortality over time. These gray bars are the admission volume, and you can see that over here on the right y-axis. And here you can see, as we go through time, what the unadjusted mortality was, and then you can look at the adjusted mortality. And in both of these cases, it is definitely decreasing. So obviously, this would not be answered by increase in testing, because here we have a population in the hospital. Ostensibly at the beginning, they were being tested, and here towards the end, they're also being tested. So this seems as though there is a very real decrease in the mortality of hospitalized patients. Here is another table looking at the demographics and mortality by week of admission, and clearly you can see here on the right column, the adjusted mortality goes from a high of 23% all the way down here to 8% in June. But this is not just happening in the United States. There's a similar paper that was published in England about their experience there. And this one is titled, "Improving COVID-19 Critical Care Mortality Over Time in England, a National Cohort Study, March to June 2020. And here you can see in the results that the 30-day mortality peaked for people admitted to the critical care unit in early April. The peak was 29.1% mortality in the HDU unit, which is against the high intensive unit, and 41.5% for those in the intensive care unit or the ICU. And there was a subsequent sustained decrease in mortality risk until the end of the study period, which was at the end of June. And they noticed that there was a decrease of 11.2% per week in the HDU and a 9% reduction in mortality per week in the intensive care unit, to the point that they concluded that there was a substantial mortality improvement in people admitted to the critical care unit with COVID-19, with markedly lower mortality in people admitted in mid-April to May compared to those earlier in the pandemic. And they said that this trend remains after adjustment for patient demographics and comorbidities, suggesting that this improvement is not due to changing patient characteristics, but actually might be part of effective treatments as part of clinical trials and falling critical care burden. So what do the authors attribute this to? Yes, it could be that we're getting better and better at detecting these patients, finding them, treating them early, and raising awareness so that these patients actually seek medical attention earlier. It could also be, as they mentioned here, that there are standardized treatments and protocols and things of that nature. And of course, it's always good to make sure that the hospitals are not filled to overcapacity, because then the quality of care for everybody goes down. Could it also be that the virus is mutating and maybe there's a softer version of COVID-19 that's going around? Another possibility that's raised by Horwitz and Mateen is that the factors which are outside of doctors' control that may be playing a role in driving down mortality. For instance, it says here that Horwitz believes that mask wearing may be helping by reducing the initial dose of a virus a person is receiving, and thereby lessening the overall severity of the illness for many patients. And we've covered that. And so it is possible that people who wear masks may be able to inhale the virus, but may be doing so in lower concentrations, and therefore giving the patient's immune system a fighting chance of actually surviving. Finally, Horwitz says, I do think this is good news, but it does not make coronavirus a benign illness. I think it's interesting, and it confirms what we have been seeing in terms of the raw numbers. So what do you think? Why are we seeing a decrease in mortality in hospitalized patients? Remember, these patients would be in the hospital whether or not they were tested, because people who are short of breath and hypoxic make their way to the hospitals anyway, in most situations. The next piece of information I want to talk about is a little more pathophysiological or basic science, and is interesting from that standpoint. Let's talk again about NAC. Now, a couple of videos ago, we talked about a study that looked at intravenous NAC, and that when it infused in COVID-19 patients in the intensive care unit for about 24 hours, there was really no improvement in these patients. Well, here's an article that looks into intravenous N-acetylcysteine for a much longer period of time and what happened to these patients in terms of their inflammatory markers. So there's a couple things that you need to know biochemically before we go on. Now, you may remember this diagram that we talked about a number of months ago when we talked about oxidative stress leading to disease. Again, in the electron transport chain, we have electrons going down the electron transport chain, finally going to oxygen, which is the final electron acceptor, and it accepts 4 electrons, which turns it into water, and that completes the electron transport chain and allows protons to go into the intermembrane space so you can make ATP. Well, we also talked about how sometimes these electrons can be put on incompletely, and you can make these reactive oxygen species like superoxide, like hydrogen peroxide, like hydroxy radicals. And these things can cause inflammation. Inflammation can lead to thrombosis, etc. But we also talked about how the body has ways that are set up to alleviate this oxidative stress. Things like catalase will convert hydrogen peroxide into oxygen and to water. Superoxide dismutase converts superoxide into hydrogen peroxide and oxygen. But more importantly for our discussion today, glutathione peroxidase, or GSH as I call it, is glutathione because the SH group is a reducing agent and peroxidase is the PX. This enzyme, glutathione peroxidase, can also reduce, very importantly, hydrogen peroxide to water through this enzyme, as you can see here. Well, and that's because it donates a reducing group and converts this SH into an SS bond. And that can be converted back into a glutathione with an SH with this enzyme called glutathione reductase. But that requires an NADPH to convert it into this reducing agent. So I want to expand this a little bit so you can understand a little bit more about the situation that we have in the early stages of this pandemic when in April and May of this year, especially on the East Coast, it was very early and they were using hydroxychloroquine at the time to treat these patients that were coming into the hospital. Now that's significant because of a particular type of patient, which is a glucose 6-phosphate dehydrogenase deficiency patient. And let me explain why that's important. So as we talked about before, hydrogen peroxide is not something that is typically good to hang around in the cells. And what we want to do is convert that as much as we possibly can to water. And the reason is because hydroxy radicals in general, or in this case hydrogen peroxide, is a reactive oxygen species, and that will eventually lead to red blood cell hemolysis. Now, as it turns out, there is some theories to believe that hydroxychloroquine can exacerbate this reactive oxygen species, at least in some patients. And so this buildup of reaction oxygen species or hydrogen peroxide can increase the amount of hemolysis in patients who are susceptible. Now let's talk about why these patients might be susceptible. First of all, again, the enzyme that is responsible for converting hydrogen peroxide into water is glutathione peroxidase. And the way it does that is by taking a GSH and converting it into a disulfide bond. So a GS disulfide bond G. But then you need to be able to recycle this back to the reduced form. And the way we do that is with glutathione reductase. And the reducing agent required for that is something called NADPH, which gets converted into NADP+. The way you recycle and get back the NADPH that you use to reduce that is through the enzyme that we'll talk about today, which is glucose 6-phosphate dehydrogenase. And that converts glucose 6-phosphate into 6-phosphogluconate. And of course, those of you who are in biochemistry know that glucose 6-phosphate goes to do glycolysis, which eventually leads to the Krebs cycle, etc. But here's the point of this, is that in patients who have low levels of glucose 6-phosphate dehydrogenase, they are not going to have as much NADPH, and therefore they are not going to be able to reduce this glutathione here from its oxidated form to its reduced form. And so therefore, what we're going to see is a buildup of hydrogen peroxide and reaction of oxygen species and lots of hemolysis. Now, just so you're aware, there are two building materials that go into making glutathione. One of those is NAC. The other one is glycine. Now, there's plenty of glycine. It's just an amino acid that's hanging around in the body. What is a building block that's very important is NAC. And so the theory is that if somebody has glucose 6-phosphate dehydrogenase deficiency here, you can bypass this deficiency by simply supplementing the patient with a lot of NAC so the body can make its own glutathione without having to use glutathione reductase. And now you can lower the amount of hydrogen peroxide and prevent hemolysis from occurring. So the question is does NAC help reduce hemolysis in patients with glucose 6-phosphate dehydrogenase deficiency? But before we look at that study, I wanted to draw your attention to a pre-COVID publication looking at the effect of hydroxychloroquine and its use in G6PD deficient patients and whether or not it causes hemolytic anemia. So it seems as though the idea that hydroxychloroquine could cause hemolysis might be overblown based on these results, because they found here that of the 275 patients reviewed, only 4% of the patients were G6PD deficient. And 2 of these G6PD deficient patients had hemolysis during severe lupus flares that occurred while not taking hydroxychloroquine. In fact, there was no reported episodes of hemolysis in more than 700 months of hydroxychloroquine exposure among the 11 G6PDH deficient patients. And so the conclusion of these authors is that the data does not support routine measurement of G6PDH levels or withholding hydroxychloroquine therapy among African American patients with G6PDH deficiency. Notwithstanding that, let's turn now to this article that looked at intravenous NAC in these patients with COVID-19. And so in this article, they look here at a patient who first came in with glucose 6-phosphate dehydrogenase deficiency. And what they're describing here is a severe case of a patient with COVID-19 who also had G6PD. Now, because this is the early portion of the pandemic, they started the patient on hydroxychloroquine. And for whatever reason, the patient started to have significant hemolysis. And what they found was that the administration of intravenous NAC severely curtailed not only the hemolysis, but also the inflammatory cytokines in this patient. Now, of course, you might be saying, well, that's just one patient. How do you know that it wouldn't have been that way if they hadn't given the NAC intravenously? Well, take a look at this patient and look at the direct bilirubin levels. Basically, in this case, direct bilirubin levels are a surrogate for hemolysis because when patients' cells break open and hemolyze, they release chemicals which are converted into bilirubin. You can see here in this square that the gray bars are the periods of time when the patient was on intravenous N-acetylcysteine or IV NAC. And you can see that whether it's direct bilirubin or total bilirubin, that when the patient was started on NAC, there was a decrease in these levels. And then when it was stopped, there was an increase in the levels. Again, decrease here in the portion of April, and then as we go out here to the end portion of April, again, a start of an increase and then a decrease once again the IV NAC was started. Here are the results for C-reactive protein. And again here, these infusions of NAC are being given over multiple days, as you can tell here. There is a ratio known as the neutrophil to lymphocyte ratio, and when this ratio is high, that is not good. That's showing more oxidative stress. And so they were so pleased with the outcome of this patient who was actually on ECMO that they decided to do it to 9 consecutive patients with COVID-19 at the Grossman School of Medicine at New York University. And what they noticed was that IV NAC was associated with a decrease in CRP and ferritin without rebound increase after discontinuation, but also there were some patients that had a rebound of inflammation noted in 6 patients following discontinuation of NAC. And so while the number of patients here is small, what makes this very statistically significant in these patients particularly is that there is a time factor associated with the infusion. In other words, when you start the infusion, the indices go in a particular direction. And then when you stop it, they go in another particular direction. Then when you restart it again, they go back down. And that is very suggestive that there is a cause-effect relationship. So you can see here the CRP in some of these non-G6-PDH patients with COVID-19. And again, the gray bars indicate when IV NAC was instituted. Here's another patient. You can see here that the ferritin rebounds after the NAC is stopped and then starts to come back down again after it is restarted. Again, here's another patient with very similar results. Here's another patient. And yet another one, very clearly here, the CRP is going up, and then on April 23rd, the IV NAC infusions begin, and it comes back down again. And here is another patient with very similar results. Something interesting about the patient with the glucose 6-phosphate dehydrogenase deficiency is if you'll notice there's a green bar here at the top, and that signifies when steroids were given. The steroids were given here starting on March 30th and going all the way through April 15th. But the gray bars here were when IV NAC was given. You can see when IV NAC stopped, the inflammatory markers went up despite the fact that steroids were still being given in this patient with glucose 6-phosphate dehydrogenase deficiency. Now, we don't have the same green bar with the non-glucose 6-phosphate dehydrogenase deficiency patients, the ones that are just there for COVID. So it's hard to tell exactly how steroids played a role in the ups and downs with ferritin and CRP, etc., with IV NAC. In fact, they say here in the article, whether these anti-inflammatory changes were specific to the use of NAC is difficult to discern from our study due to sporadic use of steroids and other anti-inflammatory drugs. However, it is conceivable that NAC has beneficial effects in reducing inflammation in patients infected with COVID-19. And of course, I agree, our observations warrant prospective studies to look at the clinical and laboratory effects of NAC and to evaluate the role of IV NAC, if any, in the treatment of severe COVID-19 patients. So overall, you can see here that the CRP levels before NAC was instituted, during IV infusion of NAC, and after discontinuation of NAC. They have a beautiful slide which hypothesizes how potentially NAC may interact with the cell and the virus, and how you can mitigate cytokine storm and the elevated CRP. And of course, we'll give you links to this article in the description below. But overall, very interesting, and I'm looking forward to more of these studies coming out. For those interested in knowing what dose that they gave, The patient in the first case was started on IV NAC on March 30th. In this case, it was 30,000 milligrams divided into 3 doses over 24 hours. So that would essentially be 10 grams of N-acetylcysteine intravenously Q8 hours. In the second phase, they started IV NAC at the 600 milligram dose every 12 hours, and even that was associated with a reduction in total and direct bilirubin. So once again, oxidative stress seems to be an issue that is front and center in the pathophysiology of COVID-19 and may be a cornerstone of therapeutics in the future. Tell me what you think below, and thanks for joining us.